Hi everyone, I want to talk to you about perioperative care today, and it's Miss Lowe. So we're going to talk about perioperative care in a couple of different aspects. So first I want you to understand that perioperative care is an umbrella. So let's put perioperative nursing. It is an umbrella under which there are three different areas that have unique responsibilities and possibilities of risks for the patient. The first part of perioperative nursing is considered preoperative. Okay, so preoperative we can think about being the patient that is coming into the hospital for same-day surgery and they're going to the pre-op area. It can also be the med-surg nurse on the unit that is preparing to send the person to surgery. So we'll talk about unique considerations of the preoperative nurse. The second stage is intraoperative. Okay, and that is actually where the patient has gone into the surgical suite, into the operating room, and what the intraoperative nurse their responsibilities are as far as what concerns they are watching for the patient. And then the final stage is post-operative. Okay, we can think about the post-operative period, and the post-operative nurse's role is to be to get the patient from the operative room, so going to a post-operative area or a PACU, which we call it, a post-anesthesia care unit, where they're monitoring and caring for the patient immediately post-op. But it can also be a post-operative period we consider to be 24 hours after surgery, where the patient's going to be going to a med-surg unit, where we'll be observing them and watching for complications over the next 24-hour period. It may be, if a patient has a same-day surgery, that they're in the post-op area for an hour and we're monitoring for complications, and then we're educating the patient and family about complications that they need to watch for at home. So let's think about what are the roles and the goals of nurses in each of these areas. Okay, for the preoperative nurse, the goals are education. Okay, we want to help educate the patient and the family about what procedure they're going to be having, as well as answer questions they may have about that, and educate them about what they're going to need to know post-operatively. So what kind of things are going to the patient can expect post-operatively, recovery time, if there's going to be certain activities that need to be learned, like using the incentive spirometer, or if they're going to be doing therapy with physical therapy, so if they've had a knee replacement. A lot of that education takes place pre-operatively so that the patient understands what their responsibilities are post-operatively, and also some of the complications that may be expected. So things like pain, nausea, vomiting, any of those things, and how we're going to help them to manage them post-operatively. Another role of the preoperative nurse is to evaluate for possible increased risks. Okay? Now when we think about evaluating for possible increased risks, think about what things may make a patient at increased risk of complications either during surgery or after surgery. So some of these things may be age, okay? So the very young or the very old. And with age, we think about that may be an increased risk of infection, okay? Let's also think about chronic diseases, okay? And what type of chronic diseases may make my person at risk intraoperatively or postoperatively. So we talk about that one of the main concerns for my patient is airway and breathing. And so chronic conditions that involve the lungs or the heart are special considerations for my patient that the physician needs to know about, as well as we need to see if the patient is healthy enough to even have surgery. What are their risks, and do they outweigh the benefits benefits of certain types of surgeries. So with the lungs, we're thinking about things like asthma, COPD, okay? The heart, okay? So any heart disease, high blood pressure, okay? Other things, diabetes, okay? So risks of hypo and hyperglycemia, okay? And how we're managing that when the person may be NPO or when they are under stress. And we said that physiological stress could be simply due to surgery or due to periods of being under anesthesia or periods of losing blood. All of those things are physiologically stressful on the body, and so the body in turn may release a lot of glucose to cope with that, or if we're in an NPO state, then we may be at risk of hypoglycemia. So remembering our chronic diseases, okay? So what are some other things? Do we have an existing infection, okay? An infection may be something that may be the reason we're going to surgery. So if there's an infection in a wound or an infection that has gotten into an organ, we may need to remove it. So if we have an appendicitis or an inflamed gallbladder, that may be why we're going in to remove it. But we're looking at the patient's white blood cell count to see if there's any other infections that we need to know about that we may need to treat before going to surgery. Think about things like urinary tract infections, pneumonia, any fungal infections, things like yeast infections, any types of skin infections, those type of things. Knowing that we're assessing a patient's history and doing a physical assessment, we're going to ask about all of these things, and we're going to also assess them with our patient, okay? So what complications or what nursing diagnosis would the preoperative nurse be concerned with for their patient? Think about things like anxiety, okay? Knowledge deficit, those are the types of things that the preoperative nurse is going to be concerned about. Okay. I gave you some handouts that were at the end of the PowerPoint, and it talks in detail about things the pre-op, post-op, and intraoperative nurse will be assessing for, and so I'm going to review those as we go out the lecture today. Okay. See if I can block off my writing here. Let's think about the intraoperative nurse. So the preoperative nurse has gotten the patient ready for surgery, and again, we're going to talk more about what that entails, but then they're going to be delivering the patient to the intraoperative area. So just like when we are transferring a person to another unit in the hospital or transferring them to another facility, if we're transferring them from the pre-op to the intra-op to the post-operative period, we're going to be giving report from nurse to nurse. So they're going to be discussing these things that the preoperative nurse has been responsible for, and also risks and concerns that the intraoperative and postoperative nurse need to be aware of. Intraoperative nursing, they're responsible for safety of the patient, okay? So what do we mean by safety? Think about in the intraoperative area that the patient is going to be giving some type of sedative, and we'll talk about the types of anesthesia, but it could be general anesthesia where they are completely sedated and they may have a breathing tube. It could be a moderate sedation where they're drowsy and not able to make decisions. It could be a local anesthetic where simply a part of their body has been numbed. But the intraoperative nurse is the patient's advocate in the intraoperative area. So we know the physician is concerned about the surgical site, the anesthesiologist is concerned about their vital signs and airway, the nurse is concerned about everything else going on with that patient. So that means we're not only observing vital signs, we're not only observing the sterility of the conditions, we're not only observing for airway, but we're also thinking about positioning, we're thinking about possibility for skin breakdown, possibility for burns in the OR. They're using lasers and they use a lot of cauterization to close wounds, so burns of patients. Again, contamination, so making sure that everybody is using sterile technique and no one's contaminating anything in the operating room. Decreased cardiac output. So how do I measure cardiac output? I'm looking at what's going in. I'm measuring intake. So we're thinking about in the operating room IV fluid. What's coming out? The amount of blood that's being, like the blood loss in the OR, as well as urine. So most patients will have a Foley catheter in the operating room, and the nurse is going to be making sure how much urine output is coming out, that the urine tubing is not kinked. They may also be putting in the Foley catheter in surgery and making sure that it's going to be attached to the bed, not lying on the floor, and that, again, everything is maintained in a sterile technique. So we said safety is the utmost important for the intraoperative nurse, advocating for safety for the patient. So we would be concerned about risk for skin breakdown, okay? We know that they're going to have impaired skin integrity if they're having a surgical wound or a surgical incision, impaired skin integrity, but we're also concerned about risk for skin breakdown, again, from possibility of burns or from lying in one position for a long time. So positioning is very important, monitoring skin integrity, okay? We said that risk for burns, contamination, and by that I mean someone having a break in the sterile field, decreased sterility, someone touching their face with their gloves, someone scratching their nose, someone not using proper PPE. We are the advocate for safety, which means risk of infection. So we're going to call out anybody in the operating room that has a break in the sterility. Contamination of a wound, again, not doing something with sterile technique. And then watching that Foley catheter or that urinary catheter to make sure that it's inserted with sterile technique, that it's, again, attached to the bed frame, and that it has good urinary output. Okay? All right. So when the patient is leaving the intraoperative area, or I'm sorry, when they're in the intraoperative area, we're going to watch a video or see a video, and I'm going to link you to it, that I want you to watch a couple of videos with this. They're short, about 5 minutes apiece. But the time out procedure is of utmost importance in the OR, and the nurse is very participating in that to ensure that safety of the patient is the utmost concern. Identifying the patient, identifying what procedure is going to happen, identifying any complications that they might anticipate that may happen during surgery, so they all can be aware of how they're going to prepare for those things before they occur. Okay? So when the patient is leaving the intraoperative area, they're going to be giving a report to the postoperative nurse. Okay? So what kind of things would the postoperative nurse be concerned about? We're going to be doing a very close assessment of our patient, meaning vital signs, dressings, so if there's a surgical dressing or drains that are attached to the patient, urine output, okay, intake, we're going to be assessing for the gag reflex, making sure our patient is alert and oriented before we give them anything by mouth, sips of liquids, anything like that. Okay? Also assessing for other types of complications. Okay? Prevention of complications. What types of complications may occur postoperatively for any post-op patient? Okay. They may have, again, impaired skin integrity. Risk of skin breakdown, again, due to positioning, due to moisture in the skin. Decreased mobility. Remember, our post-op period is up to 24 hours after surgery. Decreased cardiac output. Measuring intake and output. Okay. Also measuring vital signs. Measuring to monitor for decreased tissue perfusion. Okay, what's perfusion? Tissue perfusion is making sure that the tissues in the body, all parts of the body are getting oxygenated blood. So we said, for example, we would be checking for skin color, warm skin. We want the skin to be pink, warm skin temperature, positive pulses, positive movement, positive sensation. And if we're looking at a patient who has any type of surgical wound on an extremity, we're going to be testing for blood flow distal to that, which means the furthest distance from that. So if I had surgery on my arms, checking the hands and the fingers. If I had surgeries on my legs, checking the pedal pulses and the feet. Okay, and we're going to be looking at both sides. Why? Because we want to compare one side to the other to make sure that tissue perfusion is equal to both sides. Okay? Risk for aspiration. Okay? Again, I've had anesthesia. I need to make sure, the nurse needs to make sure that the patient is alert and oriented and that they have a positive gag reflex before giving them anything by mouth. Okay? What other things might occur post-operatively? Okay? Pain, nausea, vomiting, okay? Reactions to medications, which can occur really in the intraoperative area too, and the pre-op nurse would want to assess the patient's medications and medication allergies. Okay? Other things we're going to talk about are how anesthesia and surgery affect the GI system, the gastrointestinal system. So we said nausea and vomiting, but also we're going to be monitoring for positive bowel sounds. Okay? So during surgery, anesthesia slows everything down, and one of those things is the bowel sounds. And so what can happen after surgery is the patient will have very hypoactive bowel sounds. So we're going to be monitoring bowel sounds in all quadrants. We're going to be documenting what we hear. If a patient has decreased bowel sounds, no bowel sounds, then they wouldn't be given anything to eat or drink. Decreased bowel sounds are normal. They should be increasing as time goes by postoperatively. Therefore, the physician may order clear liquids to start with and then advance the diet slowly as the patient's bowel sounds start to increase and the GI system starts to wake up after surgery. If the bowel sounds remain hypoactive or even go to absence of sounds, then the patient may have developed something called a paralytic ileus, and we're going to look at that again in some more documentation. But the paralytic ileus, the movement of the bowels is called peristalsis, that wave-like movement of the bowels. And if they are not having that wave-like movement to move stomach acid and food contents through the bowel system, we consider that a paralytic ileus, a paralyzed ileum, or a paralyzed large intestine. And so that would be a surgical emergency. They may have to go back to surgery for that. Or if it's going to take a while for the bowel to wake up, which may happen with some types of bowel surgery, our patient may come from the operative area with an NG tube that's going to stay in place for a few days until the bowels wake up. Okay? Other things we'll have to monitor postoperatively: surgical dressings. If the patient has, again, an NG tube, to monitor placement and also to monitor output. Any drains that are coming from the site to measure output, color, and IV sites. So monitoring IV sites to make sure that they're healthy and patent, and that if they need to be replaced, most facilities, their policy is within 72 hours 72 to 96 hours to replace a peripheral IV site, then we're going to be doing that as well. Okay? All right, so we're going to be talking about all these things throughout the lecture, but I kind of just wanted to break it down and see and have you consider with each of these perioperative areas, pre-op, intra-op, and post-op, what are their responsibilities and what are the risks that they need to be mindful for during that part of the perioperative experience for the patient. Okay, so let's go on and start looking at our PowerPoint. So surgery is a significant event in any individual's life, and we'll look at there are many reasons for surgery, okay? A patient may need to have a surgical procedure due to a lot of different medical problems or injuries, or we said before it could be diagnostic. They may be going in to look around or just take a biopsy and be able to diagnose what's going on with that patient. So a surgery can be performed to diagnose a medical disease, reconstruct or remove diseased tissue or organs, improve the appearance of a person, or relieve symptoms or pain. A surgical procedure can be planned or unplanned, and the thought of having surgery can cause a patient to experience stress and anxiety, which we talked about. The patient and family may have to adapt physically, socially, and psychologically. So remember, there's a lot going on with our patients other than just the physical aspect of surgery. So let's go ahead and reiterate what we talked about before. Phases of surgery, the perioperative nursing, that big umbrella, it's care provided to patients before, during, and after surgery. Perioperative period is 3 phases: pre-op, the first phase of surgery; intra-op, the second phase; and post-op, the third phase of surgery. Okay, so let's look at some more information about that. An important task of the surgical team is to properly position the patient. So we've talked before about different positions the patient could be in, and think about whatever position the patient is in. That's a risk not only for skin breakdown, but also making sure that we're monitoring the respiratory status of the patient in some of these positions, okay? So intraoperative injuries can occur and have devastating effects on the patient, and injuries can be short-term, such as a minor discomfort, or long-term, such as pressure ulcers. The patient is commonly positioned for the surgical procedure after they've been anesthetized. Okay? The surgical team is responsible for properly positioning the patient, and during that positioning, the operating room may, on the operating room table, they may use straps, pillows, and wedges to ensure proper positioning with the least amount of complications for the patient. Failure to position the patient properly could result in an unsafe environment for the patient. So again, is the strap too tight, cutting off blood flow? Could the patient fall from the operative table? Common positions used in the operating room include supine, dorsal, recumbent, prone, lithotomy, sitting, lateral, Trendelenburg, and jackknife position. And so again, these depend on what type of procedure is going to be occurring. So let's look at some evidence-based practice. Preoperatively, we're going to be doing some things to help prepare the patient for surgery, okay? Some of these things may be showering, so patients may be instructed to shower before they come into the hospital, or if they're in the hospital the day of surgery, using an antimicrobial soap. We may also be assisting them with doing a preoperative scrub, and so the area that they're going to be having surgery on, the patient may do an antimicrobial soap, and then we may use other things like chlorhexidine, again, which is another antimicrobial soap on an area to make sure it's clean before they go to surgery. Okay. Hair removal may also be needed, so decreasing the risk of hair in a certain area can decrease the risk of infection. Many years ago, we used to use razors and shave, like straight razors, and shave people's chest or legs wherever they were having surgery, and we don't do that anymore. If you cut someone with a razor, the increased risk from infection is much higher because we could introduce infection into that area. So we're only going to use electric clippers or electric razor to trim the patient's hair in that area. We also want to document. So if we've been given an order to help the patient shower with antimicrobial soap, or if we're given an order to shave the patient, then we're going to document exactly what we were instructed to do. So we said before that a handoff communication takes place between the pre-op, the intra-op, and the post-operative nurse. It's not uncommon for anesthesiologists to also provide a handoff report to the post-operative nurse. So they're going to tell things like the type of anesthesia that was used, any complications with airway or vital signs that were noticed during the intraoperative period. They're going to tell the post-operative nurse about that. During the post-op phase, the patient will begin to recover from surgery and anesthesia, and we said it may take 24 hours or longer for the patient to recover from the effects of surgery. So the nurse assesses the patient's response to the surgical procedure. They carry out nursing interventions that will prevent complications and promote healing and comfort for the patient. Priority nursing assessments include assessing the respiratory, circulatory, so the heart, and neurological status of the patient, their cognitive status, being alert and oriented. The pain level is monitored, blood pressure, pulse oximetry, cardiac monitoring are initiated. So in the postoperative period, we said it's the third phase of surgery, and it begins when the patient is admitted to the post-anesthesia care unit or transferred from the operative room or the intraoperative area to the post-anesthesia area, and it ends when the patient is completely recovered from the procedure. So we can say that the post-operative period can be anywhere from 24 hours on, but we're going to be doing close monitoring of the patient for the first 24 hours. The circulating nurse is the person that's in the operating room that is going to be the advocate between the patient and the other people that are in the operative area, such as the surgical team. And so they are going, the circulating nurse is going to be making sure that everything is going well for the patient in the intraoperative area, and they're the advocate for that patient. Okay. So surgical procedures can be classified according to their purpose, the degree of urgency, and the degree of risk. The classifications assist the nurse in recognizing the level of care that's required for that patient. Keep in mind that these classifications can overlap, so one is not exclusive of the other, and surgical procedures can be grouped based on a patient's medical condition. So the purposes of surgical procedures, we said one may be diagnostic, so they're actually doing surgery to investigate what may be going on inside with the patient and confirm a diagnosis. So scopes are one of the things that is used diagnostically. A laparoscopy of the abdomen, so going in to the abdomen to see if there is an enlarged gallbladder or an enlarged spleen, so that they can go in and see what is going on with the patient and what treatment needs to be used based on what's going on with the patient. Another type of surgery is an ablative surgery, and so it removes a part of the body that's diseased. So, for example, if a person has diabetes and has an ulcer on their foot that hasn't healed, they can get gangrene in that toe, and it has necrotic tissue, and if that necrotic tissue is not removed, it could spread to other areas. So an ablative surgery may be going in and removing that gangrenous toe. It may also be going in and removing an inflamed gallbladder or an inflamed appendix. Constructive surgery restores functioning that's been lost or reduced. So again, a cleft lip or a cleft palate, reconstructing or constructing a part of the body so that it functions better. Reconstructive or restorative restores function or appearance to traumatized or malnourished tissues. So this has a skin graft for a burn victim, hand surgery, restoring function that has been lost. Okay, the difference between reconstructive and constructive is that constructive is kind of building up of tissue, and reconstructive is more repairing tissue that's been damaged. Okay. Transplant is replacing dysfunctional body parts. So again, transplants can be done of hearts, kidneys, livers, any of the transplants. Palliative improves comfort, decreases pain or symptoms, doesn't cure. Remember, we said some surgeries may be done just to promote comfort for parts of their life. So if a patient, again, has a tumor that's obstructing their digestive system or that's in their airway, it may be removed. It may not extend their life or remove the disease process, but it is providing comfort for that patient. Cosmetic surgery improves personal appearance, things like breast augmentation, liposuction. Again, depending on, is it cosmetic for only the appearance of the person, or could it be something that is reconstructive for, so maybe reconstructing and restoring function of a deviated septum, and then also providing cosmetic appearance for improved appearance of the nose. So surgeries can be more than one. So surgery can be classified by degree of urgency. So how urgent is it? Is it a planned surgery? Is it a surgery that's done in an emergent condition? An elective surgery is a planned surgery, and so it's a procedure that can be performed to improve the patient's quality of life. Elective surgery may be a total knee replacement as a result of degenerative arthritis. So the patient's in discomfort, they have decreased mobility, and they're planning to do that surgery, and so they plan it for a further date ahead. So maybe I have surgery planned for 2 weeks, and I have because it's a condition that I'm choosing to improve. An urgent surgery is performed when a patient's health condition is not immediately life-threatening, so surgery is required within 24 hours of the diagnosis to avoid preventable complications. One condition that may be considered an urgent surgery is if I came into the ER with abdominal pain and they diagnosed me as having an inflamed gallbladder, not a ruptured gallbladder, but it was just edematous. And so they may wait till the next morning when the surgeon comes in and put me on the surgical case to perform the next day. It's not life-threatening at the moment, but it does need to be performed within about 24 hours so that we can decrease the risk of infection, getting into the bloodstream, those kind of things. And then an emergent surgery is a surgical procedure that's unanticipated and it's performed immediately to preserve the life of the patient, a body part, or body function. These many times can result from things like auto accidents, traumatic injuries. Also, if a patient comes in and they have signs and symptoms of a stroke, and so they assess the patient and discover that they have a blood clot that needs to be removed, or even bleeding in the brain, and it's urgent that they go in and repair that to prevent permanent damage to the patient. Okay. Surgery can also be classified by degree of risk. So the degree of risk of a surgical procedure varies depending on the surgical procedure, the health status of the patient, any coexisting illnesses, and physical fitness of the patient. Okay? The healthy person with no pre-existing conditions has a better chance of surviving surgery without complications. Some health conditions increase risk and may cause surgery to be canceled until the patient has an improved health status. Some of those things may be elevated blood glucose, elevated blood pressure. It may be a patient that is anemic, a patient that has a low albumin, so poor nutritional status. All those things greatly increase the risks of a patient during surgery. So if it's not an emergent surgery, they may postpone that surgery until the patient's state of health has improved. Okay? So minor surgery may require little or no anesthesia or respiratory assistance. Most minor procedures are associated with very few postoperative complications. Things like cataract surgery, a breast biopsy, they're considered minor surgeries, and they may be done outpatient. We can also think about surgeries that happen very quickly. So a minor surgery may be if a person has a large cut or wound that needs to be sutured. Okay? Major surgery is when there's a higher risk to life of the patient, and surgery involves reconstruction or alteration in a body part. So it could be replacement of a joint, so knees or hips. It could be removal of things like tonsils, appendix, um, a hysterectomy. All of those things require anesthesia that may be general anesthesia, so more complicated anesthesia, risk for more blood loss, involvement of vital organs, and higher risk for postoperative complications. So what types of diversity considerations can increase a person's risk of complications or other problems that they may have in the intraoperative period? One thing we said is lifespan. Older adults and children have a greater risk for associated with surgery. So it may be us thinking about a knowledge deficit. It may be thinking about cognitive status, the ability of patients to understand what's going to happen intraoperatively and postoperatively. It may be our interpretation of pain, or it may be our risk of infection due to our immune status. Other things we can think of may be nutritional status and the ability of those types of patients to be NPO for an extended period of time. Culture, ethnicity, and religion. Cultural influences, beliefs, and practices could influence how a patient responds to surgery and pain. Again, we've talked about, when we talked about ethnicity and religion, about how patients view pain, how they might view a caregiver of the same sex, what kinds of consequences that they may anticipate as far as advanced directives. All of those things may be influenced. It may also be depending on if this patient believes that the surgery is necessary, or that they are going to consent to use of things like blood products during surgery. Any disability or disorder that causes extreme anxiety, hinders the ability to understand, interferes with coping with the stress of surgery, and impedes the patient's ability to respond appropriately, can increase the risk for surgery and postoperative complications. And then morphology, okay? So nutrition can lead to delayed wound healing, infection, fluid and electrolyte balances, and fatigue. Obesity can also cause significant mechanical difficulty for the surgeon. So it could be that the patient who is obese needs more anesthesia, which again would lead to increased risk for cardiac output and monitoring of vital signs. It could also be more difficult to intubate a patient who is obese for using of a ventilator during surgery. It may be a patient who needs a larger operating table or different types of equipment to be able to get down to the layers of the tissue that need to be operated on. Okay, so that person would be at increased risk of complications. And as well as we said, obesity makes someone more at risk for infection, and also could be blood loss if they're in surgery for a long period of time. So what other factors can affect surgical risk? General health are things that we were talking about as far as what is the patient's daily health like? What is their health status? Do they have any chronic conditions? Things like anemia, diabetes, infections, cardiac problems, respiratory problems. Again, with medications, are they taking any beta blockers that would decrease their heart rate? Are they taking insulin? Are they taking any medications that can make them have decreased fluid balance, things like diuretics? What is their mental and cognitive status? So are they able to understand and consent for surgery and understand post-operative care? Nutrition of the patient. Not only are we thinking about nutritional status preoperatively, so what is the prealbumin and albumin of the patient? What's their fat stores? What is the risk for skin as far as bony prominences and the amount of adipose tissue? But even what type of surgery are we doing? And are we doing something that the patient's going to have an NG tube? And so we need to be considering if we're going to use tube feeding for the patient. Is the patient able to chew and swallow after surgery, so risk for aspiration, nutritional restrictions, so again things like being diabetic, having cardiovascular disease, poor dentition, difficulty with swallowing, any cardiac disorders. So those are things like history of a heart attack, history of high blood pressure, history of AFib, that the patient may be on blood thinners, which can again increase the risk for bleeding, blood coagulation disorders, respiratory disorders, so any patient that may be on oxygen, patient that may have pre-existing problems with respiratory status, chronic obstructive pulmonary disease, asthma, renal disorders, so disorders of the kidney. We know that it's important that the kidneys get oxygenated blood and also are able to filter out waste products as well as fluid from the body. So monitoring their intake and output. Is it's a person who has chronic kidney disease and is on dialysis. So when did they last have dialysis? What is their lab results look like? Their BUN and creatinine for their kidneys. When are they going to need dialysis after surgery? Liver disease, we said the liver metabolizes medication. It's also responsible for vitamin K and some of the other clotting factors that are in our blood. So if a patient has liver disease, they may have increased risk for bleeding due to problems with those clotting factors, and they also may not be able to metabolize medication correctly. So anesthesia and other medications may stay in their bloodstream for a longer time and could lead to toxicity. Diabetes mellitus, of course, looking at risks for hypo and hyperglycemia and regulating if the patient's on insulin or what medications does the patient use to regulate glucose, and making sure that we understand, which we'll continue to learn about diabetes, that blood sugar levels that are elevated put the patient more at risk for infection and difficulty with wound healing. So we'll be asking the patient preoperatively if they've used any illegal drugs, illicit drugs, any nicotine, are they a smoker? Smoking puts the patient at risk for decreased oxygenation and problems again with their airway during surgery. So they may instruct the patient to stop smoking 24 hours before surgery, and knowing that it makes them have an increased risk of things such as a laryngospasm. And so the laryngospasm is a brief spasm of the laryngeal muscle that helps the person to swallow and to breathe. And with those spasms, it could decrease oxygen flow into the body and the release of carbon dioxide. One other complication of surgery, which we'll look at in more detail, is called malignant hyperthermia. And so preoperatively, we're going to be asking the patient if they've had any negative reactions to anesthesia in the past, or if they have a family history of negative reactions to anesthesia. Malignant hyperthermia is a rare inherited disorder that prevents the patient from metabolizing anesthesia correctly. And so it can be anesthesia that's injected or inhaled. Most of the time it occurs with anesthesia that's inhaled, and so the patient can have life-threatening complications from that. So we're going to be assessing for that, as well as their previous history of surgical procedures. Again, how did they tolerate anesthesia? What negative reactions to anesthesia did they have? Was it an airway problem? Was it nausea and vomiting? And then knowing about other surgeries in the same area could also let the physician know about any scar tissue or adhesions that they may encounter during the surgery. So during types of surgery, we said that it may be for different reasons and different risks may be involved. Also mentioning at this point that surgery can take place in a hospital surgical suite or an outpatient surgical suite. So there are freestanding surgical centers like Lexington Surgery Center where patients come in and they get surgeries for same-day surgeries. They go to the recovery room for an hour or so to monitor vital signs, to monitor respiratory status, and then they're discharged home. So the surgical suite has the same risks, either if they're at a freestanding surgical center or whether they're at in an inpatient hospital surgical setting. And so the role of the nurse would be the same in being an advocate for the patient. and there also should be the same checklists and the same safety and procedures that go into place. Okay. So what are some of the safety concerns during surgery? The perioperative nurses should be knowledgeable of the Association of Perioperative Registered Nurses standards and recommended practices. And so it's imperative that the standards are integrated into clinical practice every day. And so we have checklists for things, and they also recommend what the responsibility of the perioperative registered nurse is in the pre-op, intra-op, and post-operative areas to keep that patient safe, and also what kind of complications would we be monitoring for those patients. So nurses participate in patient safety programs and hold peers accountable for all safety standards. The communication style of the nurse could have a positive impact on patient outcomes. Being assertive rather than aggressive is viewed more positively, and to achieve positive patient outcomes, mutual accountability of all healthcare team members is needed. Accountability is achieved by preventing errors from occurring and taking responsibility when they do happen. So having that patient safety culture in combination with working as a team, good communication, and everyone being accountable for safe patient care is of utmost importance. I've linked a video that I want you to watch on Moodle that has to do with the perioperative nursing experience, and it talks about how the perioperative nurse is preparing for a surgery for the intraoperative experience and the timeout and safety considerations that are taken into place and that are important for the nurse and the patient. So let's look at anesthesia during surgery. And so anesthesia, again, is going to depend on whether it's a mild or moderate procedure, how long the procedure is going to take, and what area they're going to be operating on. So anesthesia agents are chosen by the anesthesiologist and the anesthesia team. In the video that you'll watch, you'll see that the anesthesiologist comes and talks to the patient individually about their previous history of surgical experience. So he's going to ask about any chronic conditions the patient has, any medications, any history of negative experiences with anesthesia. Has the patient had anesthesia in the past? They're also going to be looking at the patient's airway, because the anesthesiologist is going to be monitoring keeping a patent airway of the patient, whether that is monitoring vital signs or if it is with general anesthesia, they're going to be using, the patient will have an ET tube and be intubated, and so they're going to be monitoring the ventilator at that time. So let's look at some different types of anesthesia. Moderate sedation is also known as conscious sedation, and it includes an altered state of consciousness, providing a moderate to deep level of anesthesia. Amnesia, the patient's not going to remember being in the operating room, and analgesia, pain relief, that minimizes pain and discomfort. So sedation is a state of calm or reduced anxiety. Patients receiving conscious sedation may be asked to speak or respond to verbal cues during the surgical procedure, but they're not going to remember. Moderate sedation is used in things like root canals, when they do dental procedures. It also may be used if they're going in and doing certain types of surgeries like nasal surgeries, things like that, where the patient isn't going to be intubated. And so again, that depends on the risk factor for the patient, preferences of the patient, many times talking with the physician, and what type of surgery they're going to do. The nurse is prepared to respond appropriately if the patient becomes heavily sedated or other complications develop. Again, airway and looking at vital signs of the patient. Respiratory status, pulse oximetry, heart rate, blood pressure, also looking at urinary output. Okay. General anesthesia causes a loss of consciousness, loss of sensation, amnesia, analgesia, and skeletal muscle relaxation. So when we're talking about skeletal muscle relaxation, we're also talking about the airway. So the patient needs to be intubated and have an ET tube down their throat, down their trachea, helping them breathe. So they're going to have a ventilator if they're using general anesthesia. The term balanced anesthesia is often used to describe general anesthesia because the goal is not only to provide that loss of sensation and amnesia, that unconsciousness of the patient, but also to help with pain control, that hypnosis, so the patient will be completely sedated and they're going to be immobile during surgery because we don't want them to move during the surgical procedure. So let's look at the 4 stages of general anesthesia. In the first stage, it's called first stage is analgesia. Okay, so the patient's awake. They're giving them IV anesthesia, or they're giving it in a mask with a gas, and many times they use both. The patient becomes drowsy, they lose consciousness, they experience pain relief or loss of pain sensation. In the second stage, it's excitement. It begins with loss of consciousness, excitement of muscles. Okay, so that's where laryngeospasm can happen, involuntary movement of muscles, kind of like when the patient's falling asleep. Muscles become tense, breathing may be irregular, and then it ends with regular breathing and a loss of those eyelid reflexes. So we said loss of skeletal muscle, and so those muscles in the body that control things like the respiratory status, the eyelids, all those types of things are going to be relaxed. In stage 3, surgical anesthesia, vital signs and reflexes are depressed, so decreased heart rate, respiratory rate, O2 sat, blood pressure, skeletal muscles relax, breathing is regular, the operation begins. And so that means that we have to assist the respiratory status with a ventilator and an intubation of the patient. Stage 4 is the medullary paralysis. So the respiratory center in the medulla oblongata of the brain ceases to function. So we have to help the patient. Complete respiratory depression, CPR needed, death can occur. So we want to have that patient in surgical anesthesia and not go into the medullary paralysis. Okay? We want to balance in those areas. That's the main position of the anesthesiologist, is to watch for decreased vital signs, respiratory status, absence of consciousness, absence of pain, absence of muscle movement, but not complete depression of that respiratory status where CPR is needed and death can occur. Okay? A regional anesthesia is used on a part of the body where we're only going to be numbing and decreasing movement on a certain part of the body. So it's a momentary disruption of the transmission of nerve impulses to a specific area of the body. So nerve impulses, we said, can sense pain, pressure, and feeling of that area. And so we can stop that in a couple of ways. The first one is a nerve block, and so it's a form of regional anesthetic that's injected into a particular nerve or group of nerves that are surrounding tissues. So example, they may use this nerve block when they're doing a root canal, when they're going to be doing surgery on a hand, so removing some necrotic tissue, those types of things. So just numbing that area they're going to be working on and not using anesthesia to make complete decrease in consciousness with that patient. So instead of general anesthesia, which we said cardiac respiratory wise has a lot more complications, based on this surgery the physician may just numb the area that the patient's going to be having surgery on. They can also use a bear block to do this, and so the bear block is different from a nerve block. The nerve block of course numbs the nerve endings in the area, but a bear block actually blocks off the blood circulation to that area, and they're going to give numbing medication that's going to prevent pain sensation in that area by partially obstructing the blood flow to that area. So it involves the injection of anesthetic agents into the venous circulation of an extremity. And so they may be using a tourniquet in that area to prevent that anesthesia from going systemically into the rest of the body, so it stays in that area. For surgeries that are using a bear block, the surgery has to be a short time period so as not to cause permanent damage to that area from lack of blood flow. lack of oxygenated blood getting to that area. Epidural anesthesia is when an anesthetic agent is injected into the epidural space. Okay, so with epidural anesthesia, narcotics may be combined with a local anesthetic to produce a better analgesic effect. So they may use a numbing agent in an epidural, as well as things like fentanyl or morphine to give pain control. The epidural catheter can remain in place to assist with postoperative pain control, so they may come to the med-surg unit with the epidural catheter in place, and the anesthesiologist may have them on a pump that continues to give pain medication in this epidural space. So it's possible for the epidural catheter to be advanced too far, so we have to watch for complications. And we've talked before about epidurals. Complications would be decrease in respiratory status, decrease in consciousness, numbness or tingling to the extremities. We don't want that to happen. Okay. We also need to watch the external area of the patient where the epidural catheter is inserted to make sure that the dressing is clean and dry in that area. And we'll look at a picture of those in just a minute. The spinal anesthesia is when an anesthetic agent is injected into the subarachnoid space. So the subarachnoid space is in a different area than the epidural space. So the epidural space is the area that's the tissue surrounding where the spinal cord is, and the spinal anesthesia goes through the tissue that the epidural space is and goes actually into the spinal fluid that's surrounding the spinal cord. Okay. A local anesthesia is the regional application or injection of an anesthetic drug sub-Q to a specific area of the body. So they may use a local anesthetic if they're going to do something like removing a cancerous mole, or if they're going to be suturing up an area that may have discomfort and pain to it, to numb up the area. Instead of injecting agents into that sub-Q area, they could choose to use topical cream. So a topical anesthetic is like a cream or an ointment that's put on an area to decrease comfort. We sometimes used to use something called Imla cream to numb the tissues. It was a cream before starting IVs on pediatric patients. So that topical anesthesia numbed the area so the patient couldn't feel us starting an IV in that area. And so that may be used for certain patients. So this is what I was talking about, placement for an epidural versus spinal anesthesia. The epidural goes in the tissue surrounding the spinal space, in the epidural space here, and the subarachnoid space where the spinal nerve is spinal medication is injected goes through that epidural tissue into the fluid that's in the spinal cavity there. So into the spinal fluid that surrounds the spinal cord. So let's look at this question. A rare inherited disease and potentially life-threatening condition that can occur when inhaled general anesthesia is administered is called, and that is malignant hyperthermia. So we said that malignant hyperthermia, and I've posted a handout about that on Moodle as well I want you to read about, is potentially life-threatening. It's a genetic condition, so patients may not know they have it unless they've had an adverse effect to anesthesia or a family member has. So that's what we said preoperatively. We would, as well as the physician anesthesiologist, ask a patient about their history of problems with anesthesia. And so those problems would be that the patient has symptoms such as an elevated temperature during surgery, so temperature going into 101, 102 during surgery, increased carbon dioxide production, and so during surgery they're not only monitoring the oxygen saturation of the amount of O2 in the blood, but also carbon dioxide. Because of our O2, our carbon dioxide level is elevated, it's going to take up the space where O2 should be, and it also means that the gas exchange is not happening in the respiratory system. Patients may also have increased heart rate, heart arrhythmias, so an irregular heart rate, metabolic acidosis, meaning that carbon dioxide is building up in their body. And so if it's not treated, a person can die from that. So one of the treatments that is used is injection of an emergency medication called dantrolene. And again, that is in the article that I've given you to read. It requires rapid administration in the OR of dantrolene, cooled IV fluids to cool down the temperature of the patient, sedation and treatment of that metabolic acidosis. So helping the patient get rid of CO2 and increase their oxygen that's entering the body. Okay. We may also be cooling the person with a cooling blanket and continuing to monitor them in even an ICU afterwards to make sure that the patient's recovered from that incident. Okay. So let's look at some health assessment questions. What kind of things will we be asking the patient about in this perioperative period? We said that preoperatively, remember, our role is education of the patient and also evaluating for possible complications or risk factors of the patient. So preoperatively, do you have any medication or food allergies? What surgeries have you had in the past and when were they performed? Have you or any family members had any problems with anesthesia? What prescription medications are you currently taking? Do you take any over-the-counter medications, any herbal supplements, anything like that? Intraoperatively, what did we say was our concern? Safety of the patient. So are you comfortable? Do you have any questions or concerns? And I want you to understand that intraoperatively in the operating room, the patient isn't given anesthesia, isn't sedated until after they're in the operating room. So the intraoperative nurse still needs to introduce themselves to the patient, make them comfortable, answer the questions that they may have, and help them to feel safe and relaxed before surgery. Postoperatively, we're going to be assessing again for doing a thorough assessment of the patient and monitoring for complications. How's your breathing? Can you take several slow, deep breaths? What's your name? Do you know what procedure that you had? Reorienting the patient, assessing for respiratory status, cardiac status, cognitive status, neurovascular, all of those types of things. Okay. During the preoperative phase, the nurse conducts a health history and physical assessment. We talked about to identify physical and psychological risk factors and strengths of the patient. So doing education can help to identify, again, strengths. What does the patient already know? Where are they at in the learning process, as well as their health literacy? Additional information gathered consists of things like sociocultural needs, coping patterns, support systems, the patient's knowledge, understanding, and perception of the surgical procedure. The goal of the preoperative assessment is to serve as a screening process to determine whether patients are in the best possible state of health prior to surgery and to establish baseline data to compare with postoperative assessments. Okay, so what kind of testing would we need preoperative? Number one, to make sure they're healthy enough to have surgery. Number two, to have as a baseline to prepare postoperatively. We would do a fasting blood glucose. We would check electrolytes, so we're going to be learning about those. Things like potassium, calcium, sodium, magnesium, chloride. Coagulation studies, clotting factors, things like platelets, okay? Things like monitoring coagulation if patients are on things like blood thinners. Doing a urinalysis, so what is their kidney function, their BUN and creatinine, but also do they have any signs or symptoms of infection? Pulmonary function tests, how well are they breathing, what is their lung capacity? Chest x-ray, looking for any signs or symptoms of infectious process like pneumonia that could be present. Complete blood count, again looking at red blood cells, hemoglobin, hematocrit, white blood cells, and platelets. Okay, looking for signs of anemia, increased or decreased white blood cells, so risk of infection or presence of infection, and then platelets, increased risk of bleeding or increased risk of blood clots. ALT, SGPT, LDT, we're going to talk about those coming up. That's also saying that we're going to assess their liver function because medications are metabolized in the liver and the liver is responsible for storing blood clotting factors. Blood type and cross match. With blood typing and cross match, we would not only want to know what blood type the patient is, but they're going to be looking for antibodies that may be present that would prevent them from getting a certain person's blood. And so the blood bank is responsible for doing that blood typing and also matching them to other blood that may be available in there. An EKG or an electrocardiogram is looking for an irregular heart rate or problems with the electrical conductive system of the heart. Well, what would that have to do anything? Well, that may have to do with a patient that is increased risk of blood clots because of AFib. It may also be a patient who has an irregular heart condition that would prevent them from getting good oxygenated perfusion to the body. BUN and creatinine, we said, are kidney function tests, and human chorionic gonadotropin is HCG, and so that is a blood test to see if someone's pregnant, and they want to make sure that the female is not pregnant before they go to surgery, have anesthesia, have x-rays, those types of things. So they'll do an HCG if the female is of reproductive age and they've not had a complete hysterectomy. So during the intraoperative phase, an important role for the circulating nurse is to be the patient's advocate, like we said. An important task for the circulating nurse is the assessment for safe and proper positioning of the patient. The scrub nurse is also in the intraoperative period. She prepares and maintains the sterile field. The circulating nurse can provide assistance to the scrub nurse by transferring equipment and supplies to the sterile field. So the circulating nurse and the scrub nurse both work in the intraoperative period. Okay. The post-anesthesia care unit, or the PACU, the nurse that works in that area, like we said, receives a report from the intraoperative nurse. So the preoperative nurse would give report to the intraoperative nurse would give report to the postoperative nurse. Again, we're assessing for baseline and we're assessing for complications that may have occurred in the previous period of perioperative care, and also knowing what complications we need to follow up on. So in the post-anesthesia care unit, or the PACU, is the first area in the operative location where the patient will be transferred after the operating room, after the intraoperative area. People usually stay in the PACU area for at least an hour, monitoring for, again, pain control, respiratory status, cardiovascular status, any complications of the wound, making sure that they're closely monitored for about an hour before that patient may be discharged home if it's a same-day surgery, or discharged to another unit of the hospital like med-surg or ICU, where the patient's going to stay and continue to recover after that initial period. So the post-anesthesia care unit nurse, or the PACU nurse, receives a report on the patient, and that information that they're going to get from the operative nurse is about identifying the patient. Again, this is Mr. John Smith. He's 85 years old. He's a patient of Dr. Jones, and he had a right total knee arthroplasty done today. What type of anesthesia was received? So did the patient get general anesthesia? Name of the procedure performed, location and number of drains and dressings. So on the patient has a right knee surgical dressing with a JP bulb drain. The drain has had 50 mLs of serosanguinous drainage. Also, if the patient has a urinary catheter, the Foley catheter was put in during surgery. It's was put in using sterile technique. It is attached to his left leg, and he's had 1,000 mLs of clear yellow urine since it was inserted in surgery. Estimated blood loss during surgery. Again, that's going to say whether the patient had a lot of blood loss or minimal blood loss. It'll be reported in mLs, so 50 mLs, 500 mLs. That may also determine if the patient is getting IV fluid following surgery, or if they're going to be getting possible a blood transfusion. Name and amount of fluid received. So the patient is currently receiving normal saline at 250 mLs an hour to a peripheral IV in their left forearm. It's a number 22 or a number 20. Vital signs. Mr. Smith's temperature was 98.7, heart rate varied from 70 to 90, blood pressure is 140/70, pulse oximetry is 95 on 2 liters of nasal cannula. And then again, urinary output during surgery. We want to know that baseline from the intraoperative period of what to follow up on. So nursing diagnoses that are developed for each period, and we kind of looked at some of these at the beginning of our talk, but preoperatively, anxiety, insomnia, so things that are indicating worry, anxiety, problems with coping, deficient knowledge, so remember education and giving patient information in the beginning of that preoperative phase is the most important. Intraoperative, ineffective breathing pattern, ineffective tissue perfusion, risk for perioperative positioning injury, again pressure being put on bony prominences, tissues of the patient. Also positioning injury may be related to use of a tourniquet, those type of things during surgery. And then postoperative complications for the patient, not only things that we talked about as far as cardiac, respiratory, GI, urinary, but also looking at managing acute pain, managing complications like nausea and vomiting, looking for risks of infection, all those things that are going to be in the immediate post-op period in the PACU, but continuing on for at least 24 hours or longer post-operatively. So planning when we're looking at nursing diagnosis, this is one example of a patient preoperatively that was diagnosed with anxiety. And so it says anxiety related to a change in health status and fear of the unknown, as evidenced by increased blood pressure, heart rate, respiratory rate, verbal reports of feeling nervous. Okay. So the goal would be that the patient reports decrease in physical symptoms of stress. So if we're educating them about what's going to happen, what can they expect, we're hoping to reduce that anxiety preoperatively by giving them education. And then with, again, anxiety reduction or intervention being explaining all procedures, including sensations likely to be experienced either during a procedure, post-operatively, kind of knowing what to expect, okay? Collaborative interventions to help with planning. We may be working with physical therapy and occupational therapy to assist patients with assistive devices, things like walkers, crutches, canes, and also to helping them to be mobile after surgery. The UAP can also assist with repositioning patients at least every 2 hours, and then getting in the habit of looking at skin integrity as the nurse, and asking the UAP to report anything that may be suspicious to you so that you can go back and do an assessment if they notice something that you don't. The UAP can also help and encourage and assist the patient to reposition, ambulate, intake and output, going to the restroom, emptying Foley catheters, emptying drains, assessing and emptying canisters for NGs. The dietitian may provide support with nutritional problems and concerns, again, assessing the patient for risk for aspiration, a patient with decreased appetite, a patient with poor nutritional status, a patient that has complications like an infection or a wound infection or something like that that may need have increased nutritional needs that the dietitian may be consulted to help with. Application of things like sequential hose, those compression hose that are hooked electronically to massage the patient's calves to prevent blood clots from happening. Leg exercises, again, to increase mobility but also movement to prevent blood clotting. Okay. Preoperatively, we said we're going to be teaching our patient. So preoperatively, before admission to the hospital, so even if they are going to the surgeon's office, we may be in the surgeon's office teaching them about what's going to happen on the day of surgery, what kinds of things they can expect in surgery, after surgery, or as the preoperative nurse in the hospital, they may come to the hospital, get their lab work done, get their chest x-ray done, and have an appointment with the pre-op nurse days or even a week before surgery to talk about what kind of things to expect and what they need to do the morning of surgery. So if they're not in the hospital, knowing when they need to be in PO, what medications they can take, what kind of things to report to the nurse, things like a fever, a UTI, anything, a cold, anything like that, a cough, okay? What time they need to come to the hospital. So pre-admission education can increase compliance. So again, letting them know what kind of things they'll need to do to successfully be able to have surgery that day. Decrease anxiety, contribute to better performance of exercises. Again, exercises being things like learning to do foot presses in the bed, learning to that they're going to be working with physical therapy, they're going to be using a walker, learning to use the incentive spirometer. All those things are important preoperatively. Explain pre-op testing, so why I need to get labs and an x-ray and EKG and what kind of things that we're looking to get as a baseline to make sure that they're having safety during surgery and they're a candidate for surgery. Teaching the patient about preoperative washing antibacterial products. So is there a specific product like Hibiclens or just an antibiotic soap that they want the person to shower with the morning of surgery? So education can decrease postoperative anxiety. Again, teaching them the things they have control over and how they can be independent and provide success for the procedure. Exercises that need to be performed during the perioperative period are reviewed with the patient. Leg exercises, coughing, deep breathing, incentive spirometer, and can help the patient to be more successful postoperatively. Postoperatively, we said we may be sedated a little bit, we might be in discomfort. So that learning preoperatively, we just need to be reminded of it postoperatively. We're not learning all new skills postoperatively. Okay. Explain the importance of deep breathing, coughing, splinting our incision, again with a pillow or with a binder. We may be wearing a binder on our abdomen. Leg exercises, okay. Patient performs a return demonstration of exercises before surgery, so making sure they know how to do them and the most effective way so they're doing them correctly. Teaching the patient how to move in bed, and to get out of bed. Giving the patient information on how pain will be managed. Okay? Explaining that pain medication will be given to help with discomfort. Also talking to patients about the pain scale, so 0 to 10 and what that means, and answering any questions or concerns about types of medications, reactions to medications in the past, any questions about possible risks of addiction or things that they're concerned about. Providing information that can provide comfort, help the patient understand what to expect after surgery, decrease fear and anxiety. Describe the type of assessments that will be conducted. So is the patient going to have a surgical dressing? Are they going to have a drain? Are they going to have an NG tube? Are they going to have a feeding tube? Are they going to have an IV? How long are they expected to be in the hospital? All those anticipatory teachings are very, very important. Explain that the patient will be cared for in the post-anesthesia care unit immediately after the surgery. So again, where they're going to be physically located from pre-op to intra-op to post-op, that there's going to be a nurse that's their advocate in each of those areas, and also the kind of things they're going to be assessing and looking for to keep the patient safe and to also prevent complications. If it is same-day surgery, they'll need someone there during the surgery to stay in the waiting room so that the physician can keep them updated about the surgery and how the patient's doing, as well as someone that's going to be able to drive them home that day. So this talks about the cough in deep breathing techniques. So the reason that we're doing it is to encourage lung expansion. So the secretions that are in our lungs, every day when we take big deep breaths, we cough, we deep breathe, we keep the lungs opened up, which helps to prevent those secretions from pooling in the bottom of our lungs, which can gather microorganisms. And it also helps prevent atelectasis. Atelectasis are the alveoli, the big kind of grapes at the bottom of our bronchial system that expand and dilate during gas exchange. And so what happens if we're taking these shallow, small breaths after surgery, we're not getting air exchange all the way to the bottom of our bronchial tubes, and those alveoli aren't able to expand and contract to exchange CO2 for oxygen. So that prevents collapsing of those alveoli, those kind of grape-like clusters of cells. They collapse and decreases again our gas exchange, and that can lead to pneumonia for the patient, as well as that pooling of secretion in the areas can lead to pneumonia. Along with coughing and deep breathing, we'll be turning patients, moving in bed, or if possible, our patients are getting up and moving. Okay. So documentation concerns. The nurse needs to document the education that was given to the patient. So correct procedure was taught, when it was taught, note any patient concerns and discomfort, as well as if a patient isn't concerned about learning or they're not performing return demonstration correctly. Include a respiratory assessment before and after the procedure. So listening to lungs before and after they're doing the incentive spirometer, teaching them how often they should do that. So I'm also including on Moodle a short video about using the incentive spirometer. I want you to know how to use it correctly, why it's important, and then also how often we should tell the patient to do that. We should be telling them to do it 10 times every hour for the first 24 hours after surgery. And then after that, at least 10 times every 4 hours. So helping them to remember to do that, encouraging them to do that, observing them, demonstrating that is very, very important. Okay, document the number of times the patient performs each step and the patient's tolerance of the procedure. And so we'll need to continue to educate and remind the patient about the importance of that and the goals of that. So what level do we want the patient to get to on the incentive spirometer? What should they be seeing? Okay. Postoperative splinting, we said, is when a patient's putting support on an incision to provide comfort, as well as decrease the pressure on an incision that can lead to things like a dehiscence or an evisceration. Okay? So it's used during coughing and deep breathing, movement that could cause sutures to tear or to open up, and particularly we said in that abdominal area, the chest area, where there's a lot of movement going on when we're deep breathing and coughing, and also an area of pressure that's on the inside. A lot of things going on inside those cavities. So it's very important that we teach a patient to use a pillow to hold and take a deep breath and cough, or they may be wearing some type of a binder or a binding dressing to hold those wounds in place in addition to that. So what we document with splinting is document that the patient's been educated on the correct way to splint and to cough and deep breathe and why, what kind of things it does. So it can decrease comfort as well as prevent excess pressure on the incision, so it holds the incision in place, prevents it from opening up. Note any patient concerns or discomfort as well as any incidents of non-compliance. Okay, so we can educate the patient, and if they refuse to do that, or if they, even after we've instructed them about the importance of it, we still want to document that we educated the patient and the patient refused to perform, or the patient stated, I will do this after dinner, or something like that. So documenting the observance of that noncompliance of the patient, and including the assessments of the incision. So are we looking at an incision that has a dressing that's clean and dry? Is it an incision that's open to air with staples? And so we've noticed that the incision's well approximated and the staples are intact and no other signs of infection are present. So document, what does it look like? So let's look at another question. When conducting preoperative patient and family teaching, you demonstrate proper use of the incentive spirometer. You know that the patient understands the need for this intervention when the patient states, I use this device to, and it would be B, expand my lungs after surgery. Okay? All right. So other things that we're going to need to monitor for: pain management. Our patients had surgery. They probably have a surgical incision, or they may have discomfort simply from the manipulation of surgery. So how do we monitor that? After surgery, a patient's pain level, again, should be monitored frequently using a pain scale. We know that we don't have to use the same pain scale for everyone. So if a patient is able to understand and cognitively able to communicate to us the pain scale of 0 to 10, we need to explain that pain scale to them. We don't need to go into a patient who is fresh from surgery and say, rate your pain. Well, they may not know what that means. So explain the pain scale to them. I want you to tell me about your level of pain at this moment on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain you've ever had. Where on that scale of 0 to 10 would you rate your pain right now? Okay, and that's going to give us a baseline for the level of pain. It's going to help us know how to treat that, and also, again, be able to reevaluate after pain medication or pain relieving interventions to see if pain has gotten better or worse. So teach them about the pain scale. An assessment is conducted to determine aggravating and alleviating factors related to pain. So we can anticipate some things that are going to be uncomfortable for our patient. Is it a dressing change? Is it ambulating with PT? Is it moving up in bed? So can we teach them things to decrease the amount of discomfort, like splinting an incision or moving slowly, as well as pre-medicating them when we know there's going to be something painful. 30 minutes before they work with PT to ambulate, 30 minutes before their dressing change. So what makes things better or worse? And teaching patients that. If pain-controlled analgesia or a PCA machine is going to be used to control pain, we've taught the patient about the PCA and also instructed family members and visitors that they're not to push the PCA because we don't want the patient to be overly sedated, which could lead to problems with respiratory status, problems with their heart. So it could be very detrimental for the patient if other people push the pain button. Important for the patient to understand that the pain must be controlled to allow for maximized participation in post-op therapy. So again, is the patient fearful or anxious about taking medication? If they are, I don't want to take that, I may get addicted. I don't want to get that, I'm worried about getting nauseated. Talking about those concerns. So the amount of medication that they're on, the short-term amount of time that they're taking medication, the fact that they may be getting an IV pain medication the first 24 hours, but tomorrow it's going to be a pill and then it's going to be decreased from that. But if we're in so much pain we can't move, we can't deep breathe and cough, we can't ambulate, the risks for skin breakdown, the risk for infection, the risk for pneumonia are going to outweigh the complications of taking that pain medication. So ask them about their concerns, address their concerns. If they have questions that you can't answer for them, ask the physician to come back and talk to them about their concerns, okay? It's important for them to be able to verbalize those concerns to us. So we know that informed consent has to be given before a surgical procedure can happen. The informed consent gives legal authorization for the surgical procedure to take place. It can help protect the healthcare team and the hospital from claims by the patient that an unauthorized procedure was performed. So the written signature allows for the signed consent form to become a legal document. Once the patient signs the document, the consent form becomes a permanent part of the medical record. The consent form is signed before the patient is given any analgesics or sedative medication. So the physician will come speak with the patient. They're going to talk to them about the procedure, about the risks and benefits, and answer any questions that they may have about the procedure. They're then going to write an order and ask us to get a consent signed. Now, at some facilities, like my facility, which is the teaching facility, the physician or the residents get the informed consent signed. Even with that, if we're not the one that signs it or we're not the one that witnesses the signature, we have to verify in the patient record before surgery that that consent was signed by the patient and it's in the chart. So whether we're the nurse that's witnessing a signature by the patient and we're just that, we're witnessing the signature, the physician's explained everything and answered the questions of the patient, or we're the nurse that comes in the next shift that's going to be sending that patient to surgery, we have to verify in the chart that the consent was signed by the patient. Again, it's in the electronic chart that's going to be viewed when the patient goes to surgery, or if it's a paper chart, that it's actually physically in the chart that we're sending to surgery with the patient. So when a patient needs to have a surgical procedure, it's important that the patient is informed about it, about what type of procedure, about what type of anesthesia, about the complications of surgery that could happen, about the risks if they don't have surgery, and be able to answer those types of questions. It's an informed consent, an informed surgery. So if the patient has additional questions, we need to ask the physician to come back and talk with that patient before they sign the consent. The other thing that I mentioned is that preoperatively, we may be giving patients medication that's going to sedate them before we transport them to surgery. Things like a local anesthesia, things like Versed that may be an amnesiac, giving them pain medication like morphine. If patients are signing a consent and the surgery is being explained to them, that needs to be done when they're not on a lot of pain medication or they've not been given anesthesia before surgery, because they can't be considered to be alert and oriented and informed when they sign that consent. So timing of that consent is very important. So what are some of the ethical, legal, and professional practice guidelines? An informed consent, again, knowing what it is, that the medical diagnosis and reason for treatment is on there, the procedure to be performed, name and the qualifications of the person performing the procedure, name of the individuals assisting with the procedure, so it'd be the physician or the surgeon and then other surgeons that will be working as well, or residents, interns, specialists, those kind of physicians. Risks and benefits of the procedure or surgery, alternate treatment, so if they don't have the procedure done today, what are the risks of that, or what are some alternatives they could do in addition to that? That will all be written on the consent, as well as the patient has the right to refuse or withdraw consent at a later time. So if they sign that consent 12 hours ago and I'm getting ready to send them to surgery and they say, no, wait, I've changed my mind, I don't want this, they have the right to cancel at any time. They can back out of that. That isn't binding them to having that surgery done. Every person also has the right to agree or refuse medical care treatment. So when we're educating patients about things they need to do to improve their health outcomes, using the incentives barometer, certain kinds of medication, whether it's pain medication, blood thinners to prevent DVTs, antibiotics, mobility, getting up and moving, allowing us to turn them, allowing us to do dressing changes. They have the right to refuse that. We need to document that, and we also need to contact the physician to let them know, so that hopefully they can talk with the patient and again emphasize the importance of those things and their healthy outcomes. Okay? So consent is given voluntarily. The law requires the medical provider obtain consent for medical treatment. The nurse may sign as a consent form as a witness to the patient's signature. Again, if I don't see them sign that paper, I don't sign it as a witness. A legal guardian may give consent for a minor child, an unconscious patient, or someone with dementia. So are they designated as the legal guardian or power of attorney for that patient? If a person is determined incompetent by court, they will have a legal guardian that's appointed by the court that needs to be contacted to give consent for that surgical procedure. So obtaining and completing informed consent. Okay. The nurse will often witness the patient signing the consent, we said, and to the patient being competent and signing voluntarily. So the family is not coercing them or pressuring them to sign that or dismissing their concerns. You're an advocate in this response as well. The nurse is a witness to the patient's signature. The nurse witnesses the signing of the form, provides information about nursing care that will be performed, facilitates preoperative teaching, and reinforces information about the procedure. Okay? If the nurse finds that the patient doesn't understand the procedure or that the patient is unsure of whether they want to sign the consent, we would let the physician know of that situation and ask them to come back and talk to that patient. Once the consent's been obtained, it becomes a legal document and becomes part of the patient's chart. Consent forms are not legal if the patient is sedated, confused, or incompetent. When a patient refuses to sign the consent form, the nurse documents in the patient's medical record that the patient refused to sign the consent. Some organizations may request that the patient sign a release form that identifies the refusal to consent. So that may be an additional paperwork. If they refuse to sign the consent, the physician may explain to them the health consequences to not signing it, and then have them sign another paperwork that says the physician's explained the procedure and answered questions, and the patient refuses that and understands the possible implications and complications of that. So legally, that the physician and the healthcare institution are covered, that they have encouraged the patient to have that procedure, but they've refused. Okay. Preoperatively, the patient preparation necessary to get a patient ready for surgery depends on the type of surgery. And so we talked about that, whether it's a surgical cleansing scrub with an antimicrobial agent, whether it's shaving. The preoperative checklist may need to be completed prior to the surgical procedure, either on paper or in the electronic medical record. We have a preoperative checklist that makes sure that every nurse that's sending a patient to surgery does everything on there so that we're consistent in our care. And it may be dependent again on what the physician orders. So is the patient NPO? Have they had preoperative medication? So maybe the physician's ordered them to have their beta blocker, and they've ordered them to have 1 dose of antibiotics. So have they had those medications? Have they been changed into a hospital gown? Have they taken out dentures, any piercings, taken off their glasses, taken off jewelry, all those types of things. And we'll look at some other things about what's on the pre-op checklist. The nurse has the responsibility of completing the information on the checklist. You'll also check, is the consent been signed? Is it on the chart? Has lab work been done? Has the x-ray been done? So all the pre-op procedures that needed to be performed, have they been done before we're sending them to the operative area? Okay. I left some skill information in here about surgical scrubs, glove, and gowning, wanting to make sure that you understand that it's very important that everything is sterile in the operative area to prevent the spread of microorganisms, to decrease the incidence of infection. So it's important to prevent the spread of microorganisms and allow the wearers to perform activities in the operating room in comfort while maintaining sterility. So a couple of things about the operative suite are that people that are working in the operating room, the scrubs that they're wearing are not the scrubs they brought from home. So when they come into the hospital and they're going to work in the operating room, they go into a locker room where sterile scrubs are provided. They'll put on those scrubs. They also have to scrub their hands and do scrubs of their fingernails, which will be shown in the video that you have. And before they actually go into the surgical operative area, they have to put on a sterile gown on top of their scrubs. They have to put on a surgical cap, shoe covers, gloves. All those things are worn back in the operative areas. The whole operative area, including each operating room, is a sterile environment. So when they leave that environment, they have to strip off the extra PPE, and they have to put on new PPE when they come back into the operative area. Okay? So I'll let you read over this with wearing the gown and the gloves, but I want you to understand why it's so important. Okay? Talking about collaboration and delegation in the surgical suite. Okay. Evidence-based practice, I need you to read that. Okay. And who's a member of the intraoperative surgical team? So the surgeon or the physician, the surgeon that's going to be performing the procedure, the scrub nurse or the scrub assistant, which could be a registered nurse or a surgical tech. They prepare the surgical setup, handling instruments, maintaining surgical asepsis or sterile environment while draping, assures the surgeon is passing instruments, sutures, and supplies. Again, watching the other members of the team to make sure that they aren't doing things they shouldn't be, so making sure they're observing the timeout, which we'll look at, and also making sure that they are not having any breaks in the sterile environment. The circulating nurse is a registered nurse, and she acts as the patient's advocate and a liaison between scrub personnel and the surgical team. Okay? Coordinates the needs of the surgical team by obtaining supplies and carrying out the nursing care plan. She's documenting. She is observing timing of things. She is an intermediary between what she's observing that the patient needs, also observing the amount of time a patient's been in a certain position, observing skin integrity, urinary output, the amount of fluids input. So she is observing all those things and documenting those things. The circulating nurse is also the one that's going to be giving report to the postoperative nurse. The anesthesiologist will also be there, and that person is a physician administering anesthesia, monitoring the patient during surgery. There may also be a CRNA or a certified registered nurse anesthetist. And so that person also administers anesthesia and collaborates with the anesthesiologist, monitors the patient during surgery. There isn't always an anesthesiologist and a CRNA. An anesthesiologist may be the person that is in the operative area, going from patient to patient, checking in with the CRNAs, making sure that they're not having any problems. But there doesn't necessarily have to be an anesthesiologist and a CRNA in the surgical suite with the patient. Registered nurse first assist collaborates with the surgeon and the healthcare team during the procedure, so that person may also be assisting in the operative area. So let's go on and talk more about the post-op area. Okay. So the post-operative phase, the goals in this phase are caring for the patient and providing intensive immediate support. Again, we're doing assessment, looking for comparing to baseline, and also watching for complications. We orient the patient and inform the patient that the surgery is over and everything went well, or this is what, if the patient has questions, the physician will also come talk with the patient post-operatively. The nurse's goal is to promote comfort and decrease anxiety. Okay? So post-operative nurse, we said some of the priorities are airway management. That may be immediately after the patient is extubated, so the intubation tube is taken out. Monitoring for secretions, so is the patient able to swallow okay? Monitoring for signs of aspiration, monitoring pulse oximetry, oxygen status, is the patient wearing O2? Monitoring vital signs, monitoring neurological status, is that person becoming more oriented? Are they alert and oriented? Are they confused? Are they able to answer questions? How is their speech? How's their motor movement? Are they able to follow instructions? Pain management, also other postoperative complications, things like nausea, vomiting, complaints of, sometimes patients will complain of like sore throat because of the intubation tube, or even scratchy eyes because making sure that sometimes they'll tape down the eyelids during surgery because when the muscles relax, the eyes might open. So are the eyes scratchy? They may be dry from surgery. And then postoperative safety, making sure that there's no skin breakdown, the surgical dressing is clean, dry, and intact, looking at the cardiac monitor, monitoring urine output, monitoring for any signs of pressure that's on bony prominences, all those types of things postoperatively. common postoperative complications. Okay, so things we just talked about: airway obstruction, which could be life-threatening. Hemorrhage or bleeding, large amounts of bleeding can occur immediately postoperative from internal or external blood loss. External blood loss, we could be looking for things like blood in a JP drain that's a large amount, blood on a dressing, blood in the urine, blood in the stool, vomiting blood, nosebleed. Internal, we could tell if there's internal bleeding by a distended abdomen, problems with a cough, problems with chest pain, problems with decreased mental status, if it's a brain bleed. It could also be from changes in vital signs. So again, increase in heart rate, decrease in blood pressure. Signs of shock. So shock can happen if, says, the circulatory system fails to maintain adequate perfusion. That could be anything from a patient hemorrhaging and losing a lot of blood to a patient who is dehydrated and needs more IV fluid, so they've lost more blood than they've taken in fluid. So they have to have adequate blood flow to all parts of the body to avoid shock. Shock is what happens when the organs don't get oxygen from that blood. So it could be from, again, not enough input, too much output, loss of blood, and as a result the heart isn't able to pump enough blood to the body. So we'll see changes in cognition, changes in the patient's skin color, the skin getting pale, diaphoretic, increased heart rate, decreased blood pressure, increased respiratory rate. Other post-op complications are a blood clot, so a thrombophlebitis, a blood clot in the vein, and we talked about like a DVT, another name for a blood clot. So looking for signs and symptoms again of decreased perfusion to the distal extremity, looking at the feet or the hands, checking for pulses, warmth of the skin, color of the skin, movement, sensation, edema, where the area where a blood clot may be, pain, inability to move that extremity. If a blood clot becomes loose and goes to the lungs, because it moves through the vascular system, so if it breaks loose from the extremity and travels in the vascular system and it attaches in the pulmonary artery or in the lungs, the patient can have a pulmonary embolism. Patient's symptoms from that could be difficulty breathing, decreased O2 sats, bloody cough. And then watching for pneumonia, which again can be caused from infection or a foreign body. So foreign material can also be a huge mucus plug or too much secretions in the lungs. So listening to lung sounds, monitoring for temperature, encouraging that coughing and deep breathing, making sure that patients are mobile, all those types of things. Okay. And this talks about the incentive spirometer. I want you to read this, as well as there's a small video I want you to watch about that, and talking about the importance of it and knowing that it's to encourage deep breathing, maintain lung expansion, and prevent atelectasis and pneumonia. Again, atelectasis being that deflation of the alveoli, the collapsing of the alveoli, which interrupts gas exchange, and pneumonia being again from not deep breathing and coughing and mobilizing those secretions in the lungs so that those secretions pool in the lungs, which can lead to microorganisms in the lungs. Okay. So document patients' concerns, document that you educated patients, if they perform them, how well did they perform them, any complaints of discomfort, any non-compliance, making sure that, excuse me, include a respiratory assessment before and after they do activity, and then knowing that that pulmonary therapy, including cough and deep breathing, has been shown to prevent things like infections and prolonged hospital stays, infections in the lungs. Okay. Again, atelectasis, collapse are all a part of the lung, especially those alveoli at the distal part of the bronchial tubes that are help with gas exchange. Okay, looking for wound complications. So surgery may cause a disruption in skin integrity, impaired skin integrity, and it could cause the patient to, of course, increase their risk for infection. And we know other things that increase the risk of infection. So not only are we watching for complications, but we're evaluating risk factors of those patients and what kinds of things can we decrease those risk factors and which ones can't we. I can't change a person's age. I can't change a person's chronic disease state like diabetes, but I can monitor their blood glucose level and administer medication and making sure that they're on a diabetic diet. And I can make sure that I'm washing my hands and using gloves and using sterile technique when I change dressings and monitor for signs and symptoms of infection. So there are lots of things that we can do that are modifiable risk factors, and other things are not modifiable. Okay. We've talked about a dehiscence and an evisceration. Dehiscence is when the surgical wound opens up, and so the wound is not approximated or close together, and whatever's holding the incision closed, whether it's sutures or staples, begins to open back up. Sometimes it will be on one of the edges, and then sometimes it'll be in the middle, because that's where a lot of the pressure is from the inside, is in kind of that middle part that it's pulling on. Dehiscence is opening up. Evisceration is when some of the intestinal contents are spilling out of that. And we said that what we would need to do if there was an evisceration is to lie the patient down supine and to put normal saline sterile 4x4s on top of that to protect it from anything in the environment and to keep the the inside organs moist, as we call the physician, and have him come over and assess the patient. The patient's probably going to have to go back to surgery at that point. We also want to stay with the patient and keep them calm. Wound assessment. So when we're looking at a wound, what kind of things do we need to assess for, and what kind of things do we need to document? We want to know the size of the wound. So again, are we looking at a wound that has a dressing on it, or that the dressing's been taken off after surgery? Usually after the first couple of days, they may not need a dressing. So if they have a dressing, is it clean, dry, and intact? If we have a dressing that's on top of a wound that has a small shadow of drainage that we can see through that, if the drainage isn't coming through the dressing, what we would do would be to take a pin, and we could draw around the shadow of the dressing, so that the next person that comes in, or even us later in the day, can see if that wound drainage is expanding. If we have a dressing that the wound drainage is seeping through it, so it's getting their gown wet with blood, or it's getting something else with blood, we don't want to remove that first surgical dressing. I believe early in the PowerPoint it said that we can change the dressing if it's ordered by the physician or after the first 24 hours. And so many times the surgeon will come in the next morning, 24 hours later, and be the first one to change that surgical dressing, because he wants to see what the wound looks like, and also the condition of the dressing. He may also have a pressure dressing on it for that first 24 hours to provide a little more pressure to the wound to keep it closed. So he doesn't want us to bother the wound for the first 24 hours. Now, if you have a dressing where there's a lot of drainage coming out, you can reinforce the dressing, which means that you can put another dressing on top of it and tape it so that it's not getting on the patient's gown or the bedding. If there's a lot of drainage, more than just a little bit coming through that you can put a dressing on, call the physician and notify them, and just let them know there's a lot of drainage, a lot of serous drainage or sanguineous drainage, serosanguineous drainage, whatever it looks like, a large amount coming through the dressing. I wanted to know if that was normal, or if you just wanted me to reinforce the dressing. We don't see a whole lot of dressings anymore that bleed through the dressing a lot, because many wounds that are are having a lot of blood, have a drain in place. So that drain may be inserted in an area near the incision where blood's supposed to drain into. So again, if you have drainage that is seeping through the surgical wound within that first 24 hours, don't change the dressing until you call the physician, and he may just tell you to put another dressing on top of it and tape it on there, and then the next morning he'll come change it. After that 24 hours, when he comes and takes the first surgical dressing off, he's going to look at the dressing, or the incision, and he's probably going to tell you to come back in and put a dressing on it. He needs to order dressing changes. So if he puts a dressing on, or he tells you to put a dressing on and he doesn't order dressing changes, you don't change the dressing. You need to call and say, do you want us to do dressing changes? If so, how often? What type of dressing? Again, is it a dry dressing? Is it something that needs to be packed? How often are we changing it? We don't want to continue to change it if we don't have to, because it just introduces the potential for infectious material, microorganisms, to get on that incision. So it may just be a dry dressing that we change once a day or twice a day, or that we can change if it is in an area like I don't know, in an area that has a lot of friction on it where the dressing might fall off. But we need orders for that, okay? So we need to document if we're looking at the wound. We've taken the dressing has been taken off, or if we're doing dressing changes, we're going to look at the surgical wound. We need to look at the size of the wound, okay? The type of closure, okay? So it's got transverse, midline, horizontal. What I want you to know with this type of closure is, are there sutures? Are there staples? Is the wound well approximated? Okay? Edges well approximated, so which means that the incision is closed. If there's an area that looks open, or it looks like maybe there's a gap in it, it's not well approximated, and the surgeon needs to come look at that. Presence of drains. So again, is there a drain to that area? And the drain will not come from the surgical incision. There'll be a little hole or a puncture hole near the surgical incision where the drain comes out of. The tip of the drain goes into the incision, but it's not in the incision. It goes into the wound, but it's not in the incision. So you'll have the incision that can be closed, well approximated, and the drain will have another little hole near it where the drain will come out of, okay? Drainage type, color, consistency, odor, any signs of infection. So we know that the wound should be well approximated. We shouldn't see any purulent drainage, yellow or green. We shouldn't see mild edema around the incision is normal because we've cut on the skin, as well as a little mildly pink. But it shouldn't be red, it shouldn't be edematous, it shouldn't be opening up. Okay, so document what you see. If it's abnormal, calling the physician and letting him know. He may say, okay, that's fine, I'll take a look at it tomorrow, or okay, that's fine, that's normal. But if it's something that you think is abnormal, always call the physician, and then document that there was no new orders, or document what he wanted done differently, or that he came and looked at it. Okay. So this is another example. I was telling you about splinting wounds and also binders. This is another type of binder called Montgomery straps, and it actually is adhesive on both sides, so it doesn't wrap all the way around the patient. It's adhesive here and adhesive here, and then it kind of folds over the dressing. And these are like shoelaces. It just laces closed, and so it stays on the patient to kind of protect the dressing, and also kind of hold it together to help prevent that any type of dehiscence from happening. Okay, so just a type of dressing. Okay. So another quiz. Postoperatively, the nurse instructs the patient to perform leg exercises every hour. So why are we doing leg exercises? Okay. That would be D, to increase venous return, to improve blood flow, okay? It also helps to assess range of motion and maintain muscles, but the reason that we're teaching patients to point their toes to the end of the bed and then point them back up toward the head is increasing circulation of blood flow to those extremities while patients are lying in bed. And that increases venous return of blood back to the heart and prevents blood clots. Okay. What do we need to teach a patient before they go home, or what do they need to know to take care of themselves at home? Most of our patients aren't going to be staying in the hospital for extensive periods of time postoperatively. It may be a day, it may be 3 or 4 days. So the patient and the family are evaluated to determine the ability with which they can help take care of that patient at home. Some patients may require medications, dressing changes, activity limitations, physical therapy, and they also may be at risk of developing complications. Again, surgical infections. They may be at risk for falls. They may be at risk for other skin breakdown if the patient's incontinent or if they have drainage from a wound. They may be taking care of not only a dressing but a drain. They may have to do dressing changes. So do they need home health to do that with? Making sure that they have supplies that they need. Who's going to help them? How are they going to go get their medications? Are they allowed to drive? When can they shower? All these things need to be answered by asking our physician, getting those discharge instructions, and teaching the patient. And so we need to be teaching them from day one. Why are we doing the dressing change? What are these medications for? So they're learning the entire time they're there. Our patient doesn't just need to learn the 5 minutes before they go home from the hospital. Do the patient and family understand the signs and symptoms that could require the patient to follow up with a physician? It's always a great habit with discharge instructions to let them know what's an emergency and when they need to call their physician. So of course, an emergency, on our discharge sheet, it should spell out and say if you're having any chest pain, shortness of breath, or if your incision opens up, you need to come to the emergency room. If you have any signs and symptoms of infection, if you have a fever, if you have a prolonged cough, anything that could indicate that you need to see your physician sooner, call your physician's office and go in to see your physician. Some patients may have a follow-up appointment in a week. Some may not be for 6 weeks. So how do they know when to go in sooner? Does the patient and family have a plan to meet the needs of the patient? So who's going to help take care of that patient? What needs do they have? Do they need a ramp to get into their house? Do they need a walker? Do they need oxygen? Do they need a wheelchair? How often will caregivers be available to assist? Is a referral for home care needed to assist with self-care activities? Do they need to come back and get blood work done? Any of those types of things. Can the home be modified to allow necessary medical equipment to be moved into the home? When my son came home from the hospital, we turned our living room into a hospital room. We had a hospital bed, we had a wheelchair, we moved furniture out of the way so we could help him get to the restroom and get around the house. We had a ramp that had to come into the house. So we had to accommodate things before we took him home and figure out how we were going to accommodate those things. Okay. All right. So let's look at some of the handouts that I've included at the end of the PowerPoint. This one talks about our pre-op checklist, and it goes over what kinds of things that the preoperative nurse is responsible for. Preoperative education completed, informed consent signed, NPO. Have they had a bowel prep? Is it somebody that's going to have a colonoscopy or colon surgery? So maybe they not only need to be NPO, but they need to have drank medication to help clean their bowels out. Whatever was supposed to be done preoperatively, have they done that? Skin prep, any antimicrobial bathing. Also could be showering, it could be shaving a certain area. Documentation, checklist of valuables. What do they come in the hospital with? Do they have money or a wallet when they came in? Glasses, dentures, piercings, any of those things, and what were done with them. Were they put in the safe? Were they given to a family member to take home? Is it clothes, and what clothes did they come in with? And are they going to be sent to the OR with them? Have they voided prior to transfer? So letting them go pee before they go to surgery. Pre-op meds, so which ones were supposed to be given and did we chart those? Okay, so who's responsible for giving those? So many times there's medication that's on call to the OR, and so when they call from the operating room and say, this is Susie in the operating room, I'm the nurse down here, we're going to be sending a stretcher up to get Mr. Jones. Those pre-op medications many times say on call to OR, and so she would say, does he have any on-call medications? And we could look and say, yes, they want me to give him one Zantac pill with a sip of water and give him 1 dose of antibiotics. And so we can do that, and that medication, if it's a hanging IV, can go to the OR with them. So we hang it and give that to them, or we give them a pill that they should have. Make sure the side rails are up after pre-op bed is in low position. So if the patient's going to be transferred in a bed or a stretcher, that we lower the bed to a safe height and we put the side rails up for safety. Is the patient in a hospital gown? Again, we may need to ask the people in the operating room, can the patient wear their own underwear? Should they take their underwear off? But we know that they shouldn't have any dentures or eyeglasses, hearing aids, contacts, all those things. If you have a patient who says, I'd really like to keep my glasses on or I'd like to keep my dentures on until I go into surgery, it may be because they want to be able to see where they're going, and I totally understand that, or it may be someone that wants to hear what instructions are going to be given. We need to document they were left in place and let the OR nurse know Mr. Jones is coming down to the operating room and he has his hearing aids in place. He wanted to keep them in there till surgery. And so the surgical nurse can make sure that when they get down there, when they take the person into surgery and sedate them, that they can take those out and make sure they're kept safe. We just need to make sure they don't get lost. Makeup and nail polish has been removed. Nail polish again for the pulse oximeter on the finger to make sure we're measuring oxygen saturation. Vital signs before transfer, so we need to take vital signs before they go. They'll take them again when they get down there. And again, post-operatively, when they come back to the floor, we'll take them again. Pre-op lab work has been done on the chart. The surgeon's been notified if there's anything abnormal. So what if they're in the hospital and we get lab work back and their white count is 17,000, or we have a red blood cell that's very low, or we have platelets that are low or high. If they're abnormal, we need to call and let the surgeon know that we got the lab work back and there's some abnormal values, and he may ask what they are, and then we may be giving medication or we may be doing other things related to those. So maybe if the patient, his platelets were low, we may be giving him platelets before he goes to surgery, or if his red blood cells were low, we may be giving him some blood, or maybe giving him iron even. And then medication, so medication history on the chart. Make sure the medication administration record, again, that we've documented all the medications that have been given. If it's a paper MAR, that it's on the patient's paper chart going. If it is an electronic MAR, that we've documented all the meds. The electronic medical record is up to date, so we even document in there that that we gave pre-op meds, that the surgical transporter came, we transferred the patient over to the stretcher, that he went to the OR at 11:50. We don't want to wait 3 hours to document that. We want to document that immediately after it happens, so that that continuity of documentation can continue when the patient goes to surgery. And then any high alert meds noted, medication allergies, other things that they may need to know about. Okay. Here's an example of a surgical safety checklist, and of course this is intraoperative. And so I really like the example of this, looking at before the anesthesia, what kind of things should be done before the patient is sedated. Confirm that the patient understands what type of surgery is going to be done, where they're going to do it. So they're going to have I'm going to have a knee replacement. It's going to be in the right knee. The physician will mark that. So in the video I've got, it shows where the physician will sign the operative site, and so that's while the patient is awake, and he can verify, yes, that's correct, that's the knee, or that's the part of the body that's going to be operated on. Anesthesia has spoken with the patient. Pulse oximeter is on the patient and functioning. If the patient has any allergies, that they've discussed that. Any difficulty airway, so again, if someone's obese, it may be difficult to intubate them. Any history of difficulty with intubation, a deviated septum, any of the things in the patient's history that either were a history of difficulty intubating or problems with the airway. Does the patient have a tracheostomy, for example? Any risk of increased blood loss? And so if no, they've evaluated that. If it's yes, then they have IV fluids or a blood type and cross, things that they're preparing for if they anticipate blood loss of a large amount. So before they do the skin incision and the patient's sedated, so they've given anesthesia, they'll do a timeout. And so I'll let you read about that. In the video, it also shows the timeout. It involves everybody in the surgical team, and it's for safety, safety to make sure they're talking about possible risks during the procedure, and also identifying the team members. They all understand what the procedure is, and that they're identifying the patient. And then before the patient leaves the operating room after the procedure, they're going to do a sign out. So again, that's in the video as well, that talks about, again, what procedure was performed, were all the instrument counts correct, any specimens they may have gotten during the procedure, that they're labeled and so they can be sent to the laboratory. If there were any equipment problems, if there were any concerns, so were there airway concerns, blood pressure concerns, did surgery take longer than needed, did the patient lose more blood, so what concerns were there, and what did they identify could be done about that, okay? And then I've got a couple of other ones I'm just going to let you read over. Immediate post-op recovery. This talks about the recovery nurse and the things that they need to assess with the patient. So of course we're going to assess respiratory status, we're going to assess fluid intake and output, we're going to assess cardiac status, the incision, is the patient alert and oriented, and then we're going to be giving report, okay, or getting report. And then this one talks about post-op complications, the things that we talk as a post-op nurse immediately post-op, and then on the med-surg floor or ICU after the patient's had surgery. So respiratory or cardiovascular complications of the heart, infection, dehiscence or evisceration of the wound, gastric dilation. So again, is there a paralytic ileus? Is there problems with abdominal distension? What are the bowel sounds? Is the belly soft? Are there bowel sounds? Is there any nausea or vomiting? Does the patient have an NG tube? Assessing respiratory status for atelectasis, signs for pneumonia, and then for urinary retention. So knowing what kind of things we need to look for, we can reduce the risk of complications postoperatively. All right. Okay, so I'll let you go ahead and look over that. I also included 2 articles on Moodle, decreasing pressure injury, pressure-related injuries in the OR, and anesthesia in the OR. And so those are really good. I want you to read through those. And then I also put an intraoperative nurse's record in here. And so just getting you to look through here and looking at what are the concerns pre, post, and a pre and post operative, as well as in the operative suite, the anesthesia information, the assessment, medications, and it's just a good idea to be able to look through and see all the concerns that we talked about in the PowerPoint as being evaluative concerns in the operating room, okay? And so this is part of the permanent medical record that the circulating nurse will complete during surgery and be part of. This is how they're documenting in the operating room. If you have any questions, let me know. I appreciate your patience. Thanks so much. Bye-bye.